Shall we start off, Prabhu? Okay, good morning, everyone. Welcome to today's clinical meeting. We'll start off with our presentations. I hope that you've all prepared your presentations to a maximum of 8 minutes and 2 minutes for questions. We'll start off with our first presenter from Medicine 3, Dr. Tonie, with Uncommon Etiology.
Good morning, everyone. The topic for today is uncommon etiology. Presenting to you Mrs. X, 55-year-old female housewife from Kumbakonam, brought with complaints of vomiting and loose stools for 2 days and decreased responsiveness for 1 week. History of presenting illness. She was apparently well before mid-February. On 16/2/2023, overnight she developed multiple episodes of vomiting and loose stools. She had extreme tiredness and history of giddiness, required assistance to use washroom. She was made to lie down in a bed at about 4 a.m. on the next day. Subsequently, she was found drowsy, not verbalizing, and not moving the limbs. Her limbs were dragging on attempted movement and was flabby as noticed by the husband. There was no history of fever, cough with expectoration, burning, micturition, or abdominal pain. There is no history of headache, blurring of vision, seizures, or head injury suggestive of any signs of raised ICT. No history of rash over the body suggestive of any rickettsial illness. No history of prior exposure or contact with TB. No history of genital ulcer or discharge suggestive of syphilis. No history of swelling in front of ear suggestive of mumps. No history of abdominal distension or altered urine color suggestive of malaria. There is no history of chronic diarrhea with multiple joint pain suggestive of Whipple's. No history of needle stick injury, ART intake, organ transplantation, or malignancy suggestive of immunocompromised states. No history of freshwater swimming suggestive of amoebic meningoencephalitis. No history of exposure to bat or dog base suggestive of rabies. No history of beef or pork intake suggestive of parasitic infestation like Tinea solium. No history of excessive daytime sleepiness or international travel suggestive of sleeping sickness. No history of prior recurrent abortion or prolonged immobilization. She was taken to the local hospital, found to have low BP and hemoglobin, treated with IV fluids and referred to IR center. She was admitted in the new hospital from 17 to 22. She had confused and slurred speech, but she was responding to verbal commands occasionally. She was not able to sit without support. They have taken MRI, which showed multiple blood clots, and she was told like multiple blood clots in the brain will require long time to resolve and advise home physiotherapy. In view of low hemoglobin, she was transfused 1 unit of blood and the patient discharged. Past history. She is a known hypothyroid since 2015 on thyronam under mics. She is bilateral ONE. She is having bilateral ONE on tap prednisolone 5 mg BD for 4 years. Coming to examination. Pulse rate of 90, BP of 140/80, temperature 97. GCS on arrival were E3, V2, M5 around 10/15. GR is normal. So she was conscious, not oriented. Speech, she had motor aphasia. Pallor was there, no other ictus, clubbing, cyanosis, lymphadenopathy. JVP not elevated. Coming to central nervous system examination, pupils were 2.5 mm, equally reacting to light. Extraocular movements are normal, not compromised. Gaze preference towards left. Loss of nasolabial fold on the left. CAG was absent, and fundus revealed no papilledema. Coming to motor system, bulk was bilaterally symmetrical. Tone was hypotonia in the right side and normotonia in the left side. Power in the right upper limb it was 0/5, where right lower limb it was 3/5, where left side it was almost normal. Reflexes were almost well preserved. Plantar was extensor on the right side and flexor on the left side. Sensory examination were normal. Cerebellum that we couldn't able to assess, and meningeal signs were present. Neck stiffness was there. So we had the syndrome complex of loose stools followed by decreased sensorium with focal neurological deficit. So the differentials which we are considered were cortical vein thrombosis because of severe dehydration, hemodynamic stroke, meningoencephalitis, and acute disseminated encephalomyelitis. Based on the history examination, the probable localization which we considered were cortex because of the decreased sensorium and involvement of left side of the cerebrum because patient had right hemiparesis, motor aphasia, gaze preference towards the left. We are thinking more of a infarct rather hemorrhage. Pons because facial nerve palsy was there, medulla gag was absent, and we are thinking plexus also involved because there is power of 0/5 which is disproportionate to rest of the limbs. Hypotonia with 0/5, we are still thinking both cerebral and peripheral plexus also. So we went ahead with the initial investigation. Total count showed 15,600. Rest of the investigation didn't give us any path to go for further management. Rest all found to be normal except the TSH is known hypothyroid. So we went ahead with neuroimaging. In that MRI brain with contrast showed features of encephalitis with vessel wall inflammation. So we did CT angiogram, arch of aorta to circle of Willis showed no large vessel occlusion. So subsequently we went ahead with CSF. So GRBS was normal, glucose was almost normal, proteins are slightly elevated with the cell count of 25 with predominance of lymphocytosis, picture of viral etiology. So with the presentation on day 2 of hospital admission, patients started developing grouped and discrete vesicles involving right side of neck, shoulder, chest, proximal arm, and right upper back. So it was herpes zoster right C3 to C5 dermatome. So we went ahead with the biopsy which came positive for Zang antibodies, acantholytic cell. So now we are worrying about are the plexus involved because of this hypotonia involving only one limb. So we went ahead with MRI plexus, showed right brachial plexus enhancement, and we did EMG NCV that also showed asymmetric sensory motor axonal neuropathy with predominantly involved in the right upper limb, suggestive of brachial plexus involvement. Needling was not done because the lesions were contagious. So subsequently, the CSF analysis which revealed positive for varicella zoster virus, multiplex PCR came positive, where the rest of the investigation for TB or cryptococcal came negative. So with that, we have concluded our diagnosis as varicella zoster virus encephalitis with vascular inflammation and varicella zoster virus brachial plexitis and herpes zoster right C3 to C5 dermatome. Varicella zoster virus infection, there are two clinical forms. The first one would be a primary infection with varicella zoster virus, that's chickenpox. The lesions will be of different stages of development as we have seen in the top image. And the second one would be shingles, reactivation of endogenous latent varicella zoster virus infection within the sensory ganglia. There would be painful unilateral vesicular eruptions, usually occur in restricted dermatoval distribution. Usually it will not cross the midline. Coming to the pathogenesis, it's a respiratory, the root of infection would be respiratory. It infects nasopharyngeal lymphoid tissue initially. Subsequently, viremia will be there. That leads to inhibition of multiple host defense. So thereby the virus evades the immune response. And there will be prolonged incubation period that depends upon how much time the varicella zoster virus requires to overcome the local mediated immune defense, and the patient will develop chickenpox. The cell-free virus in the vesicles, they infect the nerve endings via anterograde movement along the sensory axons, and there will be lifelong latency in the neurons within the regional ganglia. Whenever there is reactivation, this varicella zoster virus spread within the sensory ganglia, involve multiple neurons via anterograde conduction via sensory nerve. The skin infection shows typical rash of shingles. The common clinical manifestation of herpes zoster would be rash and acute neuritis. Here, what we are seeing in the initial stages of rash, that erythematous base eruptions will be there. Subsequently, about a week, they form that grouped, coalescent, well-formed vesicles. After 3 to 4 days, the vesicles crust, and subsequently patient will be having hyperpigmentation. These are the dermatomal distribution of the herpes zoster rash. It follows dermatome like cervical and thoracic dermatome. So presenting to you herpes zoster associated meningoencephalitis. It typically presents with delirium or cerebral dysfunction within days following the vesicular eruption, but may occur prior to the onset of rash or following an episode of herpes zoster. Although zoster virus encephalitis is more common complication in immunocompromised, it can also seen in previously healthy hosts. Major risk factors include cranial or cervical dermatomal involvement, 2 or more prior episodes of herpes zoster, or disseminated herpes zoster, or those who with impaired cell-mediated immunity. CSF PCR assays in conjunction with MRI will give us rapid diagnosis of varicella zoster virus encephalitis. The highlighted one are the presentation of our patient. She had cerebral dysfunction with focal neurological deficit. She was a previously healthy host who doesn't have any immunocompromised states, and she had history of cervical dermatomal involvement, and we did CSF PCR assay which confirmed varicella zoster virus, and MRI brain showed features of varicella encephalitis. Varicella virus vasculopathy. It's a direct infection of the blood vessel by the varicella zoster virus. Among the virus infecting humans, varicella is the only one which is known to cause direct invasion into the blood vessel, causing transmural inflammation and vessel wall damage, with multinuclear giant cell and epithelioid cells will be there. That leads to thrombosis, necrosis, dissection, aneurysm. That's in a case of varicella vasculopathy. We used to do CT angiogram just to rule out whether does the patient having any large vessel occlusion or not. But in our case, the patient doesn't have, it came to be normal. Patient will have increased risk of stroke after herpes zoster. And the typical feature would be segmental constriction with post-synaptic dilatation will be there. But negative angiogram does not exclude the diagnosis. Varicella zoster virus plexopathy, the region where which we are having that varicella zoster, the beneath that the nerve plexus can be involved. It's due to direct invasion of the nerve, underlying nerve. If you do MRI, there will be T2 signal hyperintensities will be there, and the nerve hypertrophy can be there, and contrast enhancement of the nerves will be there. Sometimes even in severe cases, muscle atrophy can be seen. Literature showing variety of cases with varicella zoster plexopathy, there the improvement would be some are recovering completely and some are recovering with still some residual deficit. But everywhere the treatment would be antivirals followed by along with corticosteroid injection to suppress the inflammation. So the treatment for uncomplicated herpes zoster, it's mainly based on antiviral therapy, analgesia, and local or topical antibiotic. The doses used to treat herpes zoster are valacyclovir for 1000 mg thrice daily for 7 days, famciclovir 500 mg thrice daily, and acyclovir 800 mg 5 times daily for 7 days. Analgesia, we can go with NSAIDs. If the pain is not getting controlled, we can go with opioids. And local or topical antibiotics to prevent secondary bacterial infection, like povidone. For complicated herpes zoster, the treatment would be same, but the duration should be extended for 14 days. And short course of oral prednisolone 1 mg per kg can be given without steroid taper. Prevention. Zoster patients can transmit infection to who have not had varicella or who haven't received varicella vaccine. It can be transmitted either by direct contact or aerosolization of virus from the skin lesion. Patients with localized zoster are not infectious before the vesicles appear, and they are no longer infectious when the lesions have reepithelized. Until the rash has crusted, patients should be advised to keep the rash covered, wash the hands often to prevent the spread of virus, avoid contact with pregnant women who never had chickenpox or the varicella vaccine, and premature or low birth weight infants and immunocompromised individuals. Our patient, so we have continued acyclovir for almost a week duration. We are continuing for this 14 weeks at an encephalitic dose. So we consulted with neurology regarding further management. As features, everything favors presentation of varicella zoster, encephalitis, and vasculopathy. So to reduce the inflammation and sequelae, IVIG can be given, but in view of cost, steroids we are considering. Steroids also shown moderate improvement with moderate to low dose steroids. It may transiently worsen viremia, but the patient has already finished the course of 1 week course of acyclovir. Now we are planning to give injection IV methylpred 500 mg OD for 3 days. Subsequently, methylpred 250 mg OD once a week. Patient plan to review under neurology OPD for further plan on steroids and assessment on neurological function.
Can I ask something?
Yes, ma'am.
How many dermatomes was involved in this patient?
3 dermatomes starting from C3 to C5.
So when there is a multi-dermatome involvement, what are your usual risk factors?
In immunocompromised individuals like
So if it's
HIV.
multi-dermatome, it is immunocompromised.
Yes.
This patient had been receiving Decathlon for osteoarthritis needs.
Yes, ma'am.
She's been taking injections, and which is why she developed herpes zoster encephalitis. She's not a normal host who has got normal immunity. So that reduced her cell-mediated immunity, which caused this. I know you just took over the patient, so we went through her previous prescriptions for the last 2 drugs.
Thank you, Tony. What is the duration between the development of the encephalitis and the brachial plexitis? How long did it take for her to develop?
Ma'am, when she 16, she had that loose stools. She was admitted in outside hospital. At that time, sensorium, everything has dropped. When she came to us on 23rd, 25th, she developed shingles.
So this patient's encephalitis actually predated the in the appearance of the rash within a week's time.
Yes.
Usually you get the shingles and then you make it's the herpes zoster and then you may get, or alongside you may get encephalitis. This one actually predated, but it's still within 2 weeks period you'd still call it as herpes zoster.
Okay, thank you, Tony. Does anyone have any other questions?